Hello to everyone. My name is Podnar and I'm coming from University Medical Center Ljubljana, Slovenia. And the title of my presentation will be Anatomy and Scan Demo of the ulnar nerve. So the ulnar nerve arises from the medial cord C8 to D1 of the brachial plexus. Overlying clavicle obscures the view in this segment. Ulnar nerve then runs distally through the axilla, medial to the axillary artery and near the vein. It continues medial to the brachial artery as far as the midarm. You can see the position of the probe here proximal in the arm, and the structure here is the ulnar nerve. Here is the brachial artery, and these are the veins around. And this is also the anatomical picture of this position. In the midarm, ulnar nerve pierces the medial intermuscular septum and moves into the posterior compartment. Inclining medially, it descends anterior to the medial head of triceps, to the interval between the medial epicondyle and the olecranium. So this is the position in the middle of the arm, and you can see the ulnar nerve here. This is also shown, and this is the triceps muscle. This is the superficial, this is the deep part. So the ulnar nerve passes behind the medial epicondyle in a retrocondylar canal, where it is easily palpable. At medial epicondyle and 2 centimeters proximal to it, ulnar nerve can be easily externally compressed. This is the most common site of the ulnar neuropathy at the elbow. So we are positioned here. So usually we would measure the cross-sectional area at 2 centimeters proximal to the medial epicondyle. So let's talk about compression in the RTC groove. So this is the arm, this is the proximal, and this is the distal part, and this is the medial epicondyle. And you can see that in this case, the cross-sectional area of the ulnar nerve was the biggest 2 centimeters proximal to the medial epicondyle. And in this segment between medial epicondyle and 2 centimeters proximal, the conduction velocity was also the lowest, which situates the lesion to this area. So what are the characteristics of ulnar neuropathy at the elbow at this point? So it lies, as we said, at or 2 centimeters proximal to the medial epicondyle. It is more common. It occurs in non-physical workers, in non-dominant arm. It is clinically less severe, so it's mainly demyelinating, and you will never find nerve constriction in this. So we think that lesion here is caused by external compression. So at medial epicondyle, ulnar nerve lies next to the medial head of triceps and occasionally below anconos epitrochlearis muscle. So this muscle would be seen here at this position in this proportion of patients. So near the elbow also rise 2 main muscular branches of the ulnar nerve that supply flexor carpi ulnaris and the medial half of the flexor digitorum profundus muscles. So this is the medial epicondyle, this is the triceps muscle, and this is the ulnar nerve. And this is also the position where we typically measure the cross-sectional area of the nerve. Distal to the medial epicondyle, ulnar nerve runs to the cubital tunnel under the overlying arcuate ligament, so-called humero-ulnar aponeurosis, that is joining the 2 heads of flexor carpi ulnaris and entering the forearm. Cubital tunnel is the second most common site of ulnar neuropathy at the elbow, which is caused by entrapment under the humero-ulnar aponeurosis. So entrapment in this position, you can see that here we can have the very thin nerve and the thickening of the ulnar nerve proximal to this site. So this is 1 centimeter distal, and the The level of entrapment is about 2 centimeters distal to the medial epicondyle. And you can see at this position also that the conduction velocity in motor fibers is just about 10 meters per second. So let's talk about characteristics of this distal lesion. So this is 2 or 3 centimeters distal to the medial epicondyle. It is less common. It occurs in older hard manual laborers and affects dominant arm. It is clinically more severe. It is mainly axonal, and you can find the constriction in more than half of these arms. So then the ulnar nerve descends on the medial side of the forearm on flexor digitorum profundus. Proximally, it is covered by flexor carpi ulnaris. Its distal half lies lateral to the muscle and is covered only by skin and fascia. In the upper third of the forearm, the nerve is distant from the ulnar artery, but more distally it comes close-lie to the medial side of the artery. So this is the position in the mid of the forearm, and this is the ulnar nerve. It's here, and the ulnar artery just beside it. So about 5 centimeters proximal to the wrist, ulnar nerve gives off the dorsal cutaneous branch. This branch then continues distally and dorsally deep to the flexor carpi ulnaris. Then at the wrist, the ulnar nerve passes under the superficial part of the flexor retinaculum in Guillaume's canal and divides into the superficial and deep branches. You can see an anatomical picture here, position of the probe here, and here is the pisiform and the ulnar nerve, and the ulnar artery it's here. So here we see the ulnar nerve. So medial epicondyle is here, and this is the ulnar nerve. So this is the medial epicondyle. And now we move proximally. You see here on the right, and the ulnar nerve is here in the middle. And we move proximally. Proximally comes near the veins and the artery, brachial artery. And then we go down again. You see the ulnar nerve in the middle. And we go down again, and then we stop here. And we can also measure at different points the cross-sectional area. So usually we use trace technique, but here you will see the utility of ellipse. This measurement is faster, but is sometimes not so accurate. Now we move again distally towards the medial epicondyle. Now it's here, yes, you see on the right side of the medial epicondyle the ulnar nerve, and we said that this is one of the most common positions of the external compression. And you can see how inaccurate is actually this ellipse technique, but as said, is very fast. And now we move distally around the medial epicondyle, and again we are there again. This is the triceps muscle seen. These are the two heads of the flexor carpi ulnaris, and this is the place of the proximal part of the cubital tunnel. So measurement here again. So this is also the point where is the most practical to start our scanning session, because here is the ulnar nerve the easiest to identify. Also here a bit more distal. You can see above flexor carpi ulnaris, below is flexor digitorum profundus, and now the artery is coming to near the nerve, and it's also one of the positions where we often measure the cross-sectional area of the nerve. And now we move towards the wrist, and we see now it's coming the dorsal branch. Now it's going out, you see, and it's returning the okay, and now we are just distal at the wrist. You see the pisiform bone, you see the pulsing artery, and you see the ulnar nerve below the artery just near the pisiform bone. This is also the place where we often measure the cross-sectional area. So it is also important to perform a longitudinal scan. And when we do the longitudinal scan, our patient must extend the elbow, because otherwise, of course, it's not possible to do it. And even though it is sometimes quite difficult to show the whole ulnar nerve because of the anatomical way how it goes here. So you see quite a little distal to the medial epicondyle, and now the nerve will be shown in longitudinal. So it's sometimes quite difficult. Okay. See nicely. Now, usually the proximal is on the left and the distal is on the right. This is the usual convention. And then the last thing is to show displacement of the ulnar nerve. Now we see the ulnar nerve at the medial epicondyle deep down. And now when the patient flexes the elbow, actually you see that the nerve jumps over. So this is the complete dislocation of the ulnar nerve at the elbow. See? Now it's in the physiological side. And when it makes complete flexion, it just jumps over. Okay, and you can see that the nerve at this point is a bit bigger. So this might point to slight problem, but we don't have the description of patient symptoms. So that is all. Thank you very much for your attention. Bye.